Well, good morning, good afternoon, whenever you're watching this. I'm here with another conversation this morning. I've got Steve Wise here. He's an optometrist that we work with our local patients and with our prime patients. He's been around kind of collaborating with us for a while. And I know people out there, if you're into vision or you've had some experience with vision, Steve's our guy. He's the guy that does a lot of our work with us here in the clinic. So tell us kind of your background with why you got into optometry generally and kind of how that's kind of morphed into where you're at, maybe what you're doing now in general. Like I said, you're here just one day a week, a couple times a month.
Yep.
But primarily you still have a normal job, so to speak.
Normal
job.
Normal eye guy. Yeah.
Yeah.
So I graduated from optometry school in '98, but I got into optometry school because I wanted to go into something medical. So when I was in school, pre-med stuff, I was actually about this close to being a physical therapist. And I did some shadowing and some following, and
You realize that we're a little weird.
and I realized it's a great profession, but I just kept doing a little more research, and I ran into this whole optometry thing. And funny story is I'd never had an eye exam before I went to optometry school because I always had the perfect vision and didn't know anything about, you're supposed to get your eye health checked, those types of things. So I just kind of fell in love with the concept. Eyes are a fascinating thing to me, and complicated and yet, simply beautiful at the same time, which sounds kind of corny, but I just kind of fell in love with it. So I started applying to optometry schools and I got in one. And
then when you got your eyes checked,
I actually graduated. And so I've been doing it ever since 1998. So that's basically the short year.
And primarily just I don't know if this was a sound, just a plain, regular, old optometrist.
Primary care
optometrist. So you work right now primarily in the private practice.
No, I did have private practice for a while, but it just wasn't my thing in terms of dealing with
stuff,
trying to employ people, and I wasn't able to practice. I was more worried about other stuff the whole time. So I've been doing with a company called Vision Works, very large organization,
more corporate,
that allows a full scope practice setting without having to leave the office and deal with business. And
so you can just be
an eye doctor and do what I learned to do and what I love to do.
Right. So you don't necessarily have a degree or background in neuro-optometry or developmental optometry or these higher level continued or degrees that you can get as an optometrist.
Right. I went out and I just wanted to start practicing. Thought about doing residencies and things like that, but my goal at the time, I was a little bit older. I didn't actually go back to college until I was 23 years old because I didn't know what the heck I was doing. So I just kind of, I got lost there.
All right.
What did you ask me?
I said, well, you don't have a specialized degree. You're just, but that doesn't mean that you don't have an understanding of how a lens works. So there's a lot of people that say, well, I got to go find the optometrist that has the highest level of education.
Right.
Because they want to understand what we're doing unless they have this background. No.
Yeah. I don't have any specialized training in neuro or behavioral optometry, but I've been around both of those things quite a lot through my career.
So it's not you don't understand. You didn't go to school, but you do understand, and you've seen it, and you've been around it, and kind of that idea. So it wasn't weird for you when you started watching what we were doing. It says, hey, we're using lenses. So with posture, whatever that.
Well, you learn in optometry school there is some effect on the body through the vision system, but it doesn't go very in depth unless you decide to go on to specialize. So we all know that, but it kind of gets forgotten in the process of, hey, I got to learn how to do refractions. I got to learn how to treat disease. I got to learn how to do all these other things that we're known for doing. And so, it just goes by the wayside until I, met Ron and met the Hruska environment back in about 2012. And so, no, I don't have any specialized training, just a good background knowledge of how it all works and how it's all integrated through the body.
What we appreciate, what we enjoy is that Steve's willing just to actually sit down with a patient and a PT, and we just talk. Hey, here's what I see as a PT. Here's what he sees as an OD. What's the best way that we can work on this with the patient? I think that's the number one quality. That's
Right.
Hey, are we willing to at least work together to do what's best for our patients?
Yeah.
So as you're looking for somebody to work with, that's the number one quality, not necessarily the initials behind the name.
No.
Somebody that's willing to, hey, can we just work together with a patient?
Yeah.
There's some limitations in your environment now at VisionWorks, right? So it makes doing lots of things there kind of challenging. Space is a limitation. Some of the ways that we do things we'll get into later. So Steve comes to our office and we have an eye chart. If we had the room at your office, we could come to your office and do it. It's just challenging based on that space. But
20-foot rooms are hard to find anymore.
Rent is high.
Through the magic of physics and light, we use mirrors,
Yeah.
to simulate that distance for our patients these days because of obvious reasons.
Yeah.
And so it's hard to find a space.
Okay. For sure. Yeah. But for people to know, like if we had to at your office, I mean, I've been there, we could put an eye chart down in the hallway and we could go out in the hallway and we could do a standard refraction if we wanted to.
Right.
But you have to learn you got to get your tools out and do it by hand.
Yeah.
Which I know when we first started, like, I haven't done this since optometry school. I have these cool computers. You can just plug the numbers in and they do it.
Yeah. Well, and a lot of places do. I still use the old fashioned phoropter, but yeah, we could definitely do it. It would take, a little bit of extra effort, a little bit of organization, but it can definitely be done.
We just have a space here, so we do it here, which is good. But so if you're looking for people, you can accomplish these things as long as you're willing to do a little bit of effort.
Yeah.
So most of the time you're in kind of primary care, refractions, helping people out. We still send you patients over there if we need to. But then you kind of merge into a role where you're kind of a big part of our Prime team. So how long have you been with us now with Prime? We kind of tried to figure that out.
Yeah, we were just talking about that, and it seems somewhere around the end of 18, beginning of 19, pre-COVID kind of era is where I started coming over and doing these standing refractions and integrating with you and the other team here to work with patients.
Yeah. And what do you see as the biggest difference between kind of when we're working with a patient here versus what you might do kind of at your office?
Well, the obvious is standing refraction versus sitting refraction. We work in a lit environment here in more of a natural, hey, up on my feet type of world.
So we're back in the gym. The windows are open, the lights are on.
Yeah.
Standing up.
People are moving around us sometimes using other things in the gym versus.
It's a natural environment.
Yeah.
So, and I know we've talked about this, but just that environment versus sitting in a dark room with your head in the phoropter, even if you have good posture, we'll see differences just in the change of environment. What do you notice as far as just testing in this environment versus testing in your office?
Well, it's pretty much to the patient, we find more plus.
Yeah.
We can get more plus on a patient and still keep them at minimum of 20/20 in each eye individually, which usually ends up being better than 20/20 when we get them binocular.
By the time we're all done. Yeah.
Yeah.
So in general, when we have somebody that comes, the first thing I ask Steve to do is just, hey, we're in a different environment. Let's just get them on their feet. We make sure that they've got whatever they need on their feet, shoe-wise, if they need something between their feet to make sure they're not, because we're doing our PRI stuff to make sure that patient is in a good neutral state. And then all I do is ask Steve, hey, just refract them. Just test their eyes out. Nothing fancy. And then his mindset has now, well, how much power can we take away from?
Yeah, how much minus power specifically can we take away from a patient? And that's something that, we learn at optometry school, max plus to 20/20, which I think we all do a pretty good job of. But especially the myopes out there, they like to suck up minus, and so they see contrast is more appealing, or size is more appealing, or how close or far the letters look is more appealing, which can lead us down a road of giving them too much minus.
Of overprescription. Yeah. And I don't think optometrists are intentionally overcorrecting or overprescribing people, but we do see a lot of our patients that are overprescribed in that minus direction, primarily because the patients are asking for it. So you have somebody in your office and you say which one is better, right?
Yeah.
which is kind of normal.
Yeah.
Which one's better, 1 or 2? Which one's better, 3 or 4?
Yeah.
You give them what's better.
Right. What
now,
they say is better.
Yeah. What they say is better. Now I know you've changed a little bit of how you ask, so kind of tease that out a little bit instead of saying, well, which is better?
Yeah. I get very specific in asking them, can you read more letters is a big one. No. Specifically, is it just darker, or can you read more letters?
Right.
Or less letters, for that matter.
More minus will make it darker. We'll make it.
Yeah. It can change the perception of what the brain's seeing. The brain likes contrast,
Right.
which we all start to lose as we age. And so, it's very easy to give them that, even if it doesn't allow them to see more letters,
right.
Unless you're very specific. So I very specifically focus on that. I try to make sure, they're sitting in a comfortable environment, no legs crossed, no 1 foot over here, both feet on the little step down there, and try to make sure they're in a relaxed position as I can get
as much
them
as you
in.
can. And we got some stuff along with that too. But just that change of how you might ask a patient, not which one's better, but can you actually read more letters?
Yeah. Can you actually?
Is it actually beneficial for you?
Exactly.
And I think it seems to me that a lot of people, whether it's the environment that they get tested in or that mentality, well, that's the best I can get for the patient subjective report does lead to people being overprescribed minus. Now, in our opinion, as far as what we see with people who have more minus, or when we can start to take minus away, we see general levels of tension in that system be reduced.
Yeah, instantly.
Autonomic tension, visual tension, neck tension, back tension. So the level of tension that a body creates, is directed by that eyeball.
Apparently it is.
Which is really
seen it hundreds of times.
Yeah, like all the time. So just that often, here we just do that. Let's get them in a good spot and stand them up.
Mm-hmm.
Let's see how much minus power we can potentially take away without affecting clarity. Like they're still seeing 20/20 or better than 20/20. So we're not trying to affect clarity at all at this point. And we'll see tension reduce, and sometimes that's all we've got to do. It's pretty.
We start with the baseline refraction, then you take over. You do your PRI testing. You check for neutrality. You sometimes will check for, can they get into the left hip? Do they like their left side a little bit more, and those types of things.
They're balanced, and we have some function. And then I go, hey Steve, we're not quite there yet.
Yeah.
Or no, we're good, or whatever we want to do. But it's this back and forth that we have between here's what we think for visual, here's what we think for physical, and how do we get those two things to match up. So it'd be really hard for me to do it without you, and it'd be really hard for you to do it without me.
Impossible.
Yeah, exactly. Which is the thing. So if you're working with an eye doctor, the more you can integrate together and be in the same room at the same time is just there's no substitute really for
right.
it.
It's hard to substitute for that. It's not impossible,
No, we have patients. Hey, I got a patient. Well, I think you just need to go see Steve. I'll say, well, go see Steve. Here's the number in his office. Steve will even say, well, here's what I got. We probably could take more away if you wanted to, but
we can tell who the latent hyperopes out there. I mean, every optometrist out there can tell who can probably take more plus if we wanted or something.
If we wanted to, and then you get right on my prescription. They don't buy it. They come back and see me, and we build and say, okay, we're kind of close, and we can kind of go back. But it becomes a little inefficient rather than hey, let's just do it together. But for people who just have a little bit of need,
right,
it works. It works.
We just had a patient this last week with Ann that she sent over, young female that was just injured all over the place, walked in with her neck like this and limping on one side, and had plus that she just refused to wear her whole life, and was so tight that even at I think she was 20, 19, maybe somewhere in there, even at her age, she was only a +1 left and like +75 right with a little bit of still, but she couldn't get 20/20 through that without the glasses on because her accommodative system was so overused that she couldn't let it go anymore. And I just know from doing this for as long as we have that she had more plus in there, and that she would definitely benefit from wearing something full time.
So with her, now she couldn't see clearly without her glasses, but she didn't want to wear her glasses.
Nope.
But she was creating too much tension.
Way too much
with her visual system, which was showing up as a hip problem and a plantar fascia. She had plantar fascia
She had
release.
surgeries on her hips.
Hip surgeries. She was a softball player. She could barely. She looked like she was about 80 walking up and down the hall.
She was hurting.
And just getting Steve Refractor brought back and saw her last time. Man, we're off to the races now, I think, with her. So.
Yeah, and in the chair, I just got her to 20/20. I didn't push her past to blur or any of that stuff. We didn't do any of the techniques we do here with left side expansion specifically or any of that stuff.
Yeah, no, it was just a matter of showing some relaxation.
Yeah.
Now we do that and somebody's still not there. Then we got some other tools that we would do over here. We're really trying to make sure that not only are people standing, but when they're standing, they are standing in a way where their body is in as much of a neutral position as possible, which means they can sense that they've got even weight on both feet. They're not standing with, a shoulder lower, or they're all kind of torqued up. They're just, without working hard, standing up. And then, so what we'll often do is, we're not quite there yet. We'll do a little tweak some with their feet. So if you've taken the PRI courses, you kind of know what we're doing with that. But we're going to help them sense or feel something different in their body. And then all I do is tell Steve to do his thing again. And just the change of sensation of the feet, he'll find a difference in refraction.
Yeah. Could be very slight. Could be just a little axis shift of 5-10 degrees, but we see results from that.
But that can make all the difference in the world. Then when they get up and move around, they still have that sense of balance between their 2 feet. It's just a subtle change in that axis. So, which kind of leads us into when we do have somebody get a pair of glasses, we're pretty specific about how we want we want that those pair of glasses to do. And so it's kind of an underrated, I think, concept that hey, when we find a prescription, that's the prescription we want.
Yeah.
Not because it necessarily is going to matter for seeing well, but because it's going to help them with moving well.
We
but
know
maybe from an eye doctor, from an eye doctor perspective, or from somebody knows how that glasses system works, maybe just expand on.
Well, you basically said it all. I mean, it's little things can make a big difference, which we don't really realize as optometrists because we haven't experienced this.
Right.
I'm experiencing, but yeah, little differences. You get more plus, just a quarter here and there, or
which again, binocularly doesn't necessarily change clarity that much.
No.
But we see the differences physically dramatically, or a 10-degree axis change of a little bit of the sill can have impacts on what I'm doing. Now, for years, it doesn't. I mean, 10 degrees isn't going to change. They're not even going to notice.
The national standards are pretty lax when it comes to those things because, visually, it doesn't necessarily make a huge difference. But neurologically, physically, it definitely can, and we've just seen it, like I said, hundreds of times.
Yeah. So we have people go to a lab, and on our prescription that says we want this power to be exact as written, as close as possible.
I think it was a 2 degree.
2 degrees for the sill.
Even for the halves and the quarters.
And so the industry standard, in the world of eyeglasses,
7 for a quarter or a half or something like that.
I asked ChatGPT once, maybe I was 7-9 degrees, something like that. Depends on how much sill there is. What that industry, which means you send your glasses to Lens Crafters or Warby Parker, not to throw anybody under the bus, but they'll get it within the tolerance because that's the standard, but it might not be what we're asking for. And then people get their glasses and they come back and say, it's just not quite doing what those ones you had were doing.
We can put the trial frame back on with what we wanted and
see that
we're getting the results to repeat themselves.
So that's just one of those little concepts. Make sure that those glasses are done the way we do that. Any other thing that's been real surprising that you've noticed as you've kind of worked with patients? Anything that's really stuck out to you as what things that you've seen? The things that you now have, you say, man, I had some control over that? Like, that's something I did? That's kind of cool.
Well, in the beginning especially, there's wow moment after wow moment because, until you see it, it's kind of seems like hard to believe type stuff. But once you see it, you can't unsee it, and you're hooked. I mean, you know that this makes a difference, and it's been phenomenal. Learning and just having a different outlet for my skills other than just being a primary care optometrist, because these people that we see they're in bad shape. They come for Prime usually after they've been everywhere else they know to go that they can look up on the internet or anything else, and they're desperate. They come from halfway across the world, literally. We have a board out there we started putting pins in with the world map on it because we just wanted to keep track of it because it's so cool to see that people will come this far to spend 3-4 days in Lincoln, Nebraska to work with the feet and work with dental specialists, eyes, PT, of course, and then leave in a better place than they came in.
Yeah.
And found answers to things that they'd never been able to find answers to before.
And it's complex, but it's not hard.
Not hard at all.
What we're doing is
my job's easy, and I stand around and just do a loose lens refraction.
He just does whatever I tell him.
Exactly. I just do whatever I'm told, and now we've done it long enough that I kind of already know where the next thing's coming.
And there's some little subtle tweaks that we throw in there if we're still not getting things.
If we got a stubborn one.
But we're not really doing massive, things. We'll use prisms. I was like, well, I was a geoprism. Well, what's a prism?
Yeah.
Tell me what a prism is.
Prism is simply a plastic or whatever you're looking through that can create an image shift, a perceptual image shift, so that if somebody has a binocular issue and they don't want to move their eyes a certain way, well, we can move the image to where their eyes kind of prefer to be, taking off a little bit of stress from that, convergence divergence system,
which is
or double vision or whatever.
A very commonly utilized tool for neuro-optometry and even general optometry for eye alignment issues, right? But it's not the main thing that we're utilizing here, because we're not necessarily just looking at how do we move the eyeball around.
I'd say anymore, like a day like today, where we got an 8-patient day today. We'll be here all day, and we might get 1 to 2 that we might have to use a little bit on.
And that's icing on the cake after you do everything.
Yeah, that's after we've exhausted all other options.
Right, so we just need a little extra bit. So now you want to talk about any lens is a prism lens.
All lenses
are
prisms. They're either base to base or they're apex to apex, all the way around that lens, whether they're a myope or a hyper.
So, but in terms of prisms to shift things or whatever.
Yeah, that's a decentration of a prism. So now you're not looking through the optical center where all those, points come together. You're looking through either a base in or a base out, one on the side or the other, up or down.
Yeah. And that's where kind of this started, because that's, developmental neurooptometrists have been using lenses to move people, change posture, get them to stand up straight
for
a long time, particularly looking at people with brain injuries and strokes and actual, eye damage, those kinds of things that they needed that massive help, and they weren't going to get it themselves. And so that's kind of where this started. But we found people with, I don't want to say normal visual systems, but kind of normal visual systems,
mostly
not traumatic, not brain injuries, not.
Although we do get brain injuries,
we
get
if we
lots
throw
of concussions.
But we throw a prism on them, and you could see a change, it's a dramatic change. It's kind of cool. But those brains go, oh, that was a nice trick.
Yeah.
And they would tend to kind of accommodate to it pretty quickly. And
brains can be stubborn that way. They can learn to ignore things they don't want, or they don't like, or they're just not, brain's not adapted to, and doesn't respond like we'd like it to. But we don't do a lot of base in, base out. I mean, just not much. I mean, like I said, there's occasions, but pretty rare.
There's other things we do, yeah. But that's where the program started. We're using lenses to move people, and we could induce a change on somebody by putting a lens on their eye, and that takes that's where the neuro-optometrists were valuable. Well, when I do this is what's going to happen. When I do this is what's going to happen.
Yeah.
And then we would hope that patient would learn that. And over the course of time, what we developed, we went from just having a vision program that it was getting all those systems integrated, the vision with the dental, particularly with the upright floor shoe sense that really made it that I don't have to put a pair of glasses on you that you can't see well in just to get your body to move differently, that your brain may or may not appreciate over time.
Yeah.
We can give you something that you can actually see well with.
Yeah.
And it allows you to hold your body up in a way that's going to allow you to maintain good postural neutrality.
Yeah.
So that becomes you don't have to wear these glasses for just 20 minutes to do exercise and then take them off, because you'll probably get a headache if you wear them longer, which is where we started.
Oh yeah.
Right? We're gonna give you a pair of glasses. And you'll see the change. We did cool things with that, but now we can do. Hey, you can wear this all day long, and all day long you keep your body in good position.
Have that sense of relief constantly instead of just intermittently through the training process that you guys get.
So we're still learning and evolving, and things are improving as we go along here. So things that we did even in 2018 we're doing different now.
Oh yeah.
So
it's definitely evolved.
So it's evolving.
Like everything does,